PCCM, page 326, fungal skin infections, tinea/ringworm in adult or child. Now, just quickly, here's a picture of from how to treat of tinea. Straight tinea, tinea capitis, which is head tinea, tinea pedis, foot, tinea unguum, nail tinea. So the PCCM recommends preventing transmission of ringworms. Always treat secondary infection. They want you to perform a skin scraping from the edge of an affected area for microscopy and mycology if there's any doubt about the diagnosis. So that's the edge of the affected area. As a background, tinea or ringworm, so it's not actually a worm, can infect any part of the person's skin, hair and nails. It's caused by dermatophytes, a fungus parasite, and has typical appearance which is described as annular, forming a ring, or arcuate, bow-shaped. It's usually scaly and itchy, with a definite edge and central clearing as it expands. Transmission is fostered by overcrowding, shared bathroom facilities, poor hygiene, humid conditions, and being in a malnourished state. It can be transmitted by direct contact with others or by infected animals or objects, such as combs, caps, clothing, footwear, linens and wet floors, including occupational exposure. Now, it may present with the following subtypes: tinea corporis, tinea capitis, cruris, and pedis. Corporis may be diverse in presentation, but commonly presents as an itchy lesion or rash with an advancing, irregularly shaped, raised, red scaly border with central clearing. Excoriation from scratching and secondary infection is common. Tinea capitis is on the head and has a variable appearance ranging from small lumps about the hair shafts to a carrion, which is an inflammatory, boggy mass often studded with broken hairs and oozing purulent material. It's usually itchy or painful. It occurs almost exclusively in children. Small patches devoid of hair may need to be considered, i.e. alopecia areata or telogen effluvium. Tinea cruris predominantly occurs in males, and tinea pedis occurs between the toes and is characterized by itching, scaling and fissuring. So they all look like this. In terms of clinical assessment, you want to just do a full exam, do your standard obs, and blood glucose seems to be a common theme for the PCCM, doesn't it? Have a chat about nutritional status, do a physical exam. So if you've got, widespread skin involvement or tinea capitis, consult your MO. Otherwise, perform a skin scraping from the edge of an affected area for microscopy and mycology if there's any doubt about the diagnosis, but most of the time you can see the annular lesions and clinically diagnose tinea corporis. Treat any secondary bacterial infection first, so often you can have a superimposed bacterial infection, so if it looks like that, then just treat it as such and add some eupirocin. Efforts to decrease occlusion and moisture. So you want to keep the area dry. So it can be done by avoiding synthetics, wearing lighter and better ventilated clothing and footwear, by judicious use of absorbent powder. And for isolated lesions, treat with a topical agent such as miconazole 2% or clotrimazole 1%. Now on this schedule, you can proceed with miconazole 2%. So you want to use it twice a day, continue using it for every day, but then use it 2 weeks after it looks like symptoms have resolved. Clotrimazole 1%. Again, use it 2 or 3 times a day and use it for 2 weeks after resolution. You want to review the patient every 2 weeks or proceed on. If there's widespread skin involvement, tinea capitis or fingernails or toenails are involved, and if they are, you just often need to proceed on to next level treatment, terbinafine. So I guess these creams are fungostatic and terbinafine is fungocidic. So this will kind of stop the fungus a bit without killing it. Your immune system takes over, and terbinafine is a bit stronger and actively will kill the fungus.